So, Dr. Sudak, what would be another example of a simple high-yield CBT intervention that we can do, in a few minutes when we are seeing patients
Sure.
for short visits?
So another thing that I think can be really helpful is working with medication adherence with CBT techniques, because that's just a huge problem.
Right.
And so first, one of the tenets for us is being able to educate the patient as to the ubiquity of adherence problems. That just coming right out with talking about how it's really difficult to take medication every single day, and asking questions that are more likely to get the truth. Because if you think about it, if I ask a question in a group of physicians, how many of you have taken every single dose of antibiotic that was in the bottle? Not as many people raise their hand as would be optimal.
Right.
And if you were my husband, you'd say, "Oh, they must have given me an extra pill at the pharmacy." But some people would, but how many of those people actually told their doctor they didn't take all those doses? Probably very few.
Yes.
The fact is that everybody wants to be a good patient. So we have to give people the chance to tell us the truth. And there are lots of ways of doing that. You can, most people, if I watch residents, the first question they'll ask patients is, are you taking all your medicine? Now, the answer to that is almost invariably yes.
Yes. Mm-hmm.
And so we have to tailor questions that are the most likely to get the answer. So how many times have you had trouble taking the medicine? Being able to talk about the ubiquity of problems with taking.
So can I assume that they might have had difficulties?
Assume non-adherence.
So
assume there'll be troubles.
How often did you miss the medication
Exactly.
in the last 2 weeks? Okay.
Additionally, sometimes it's even reasonable to share with them that you've had trouble taking medicine every day, that things get in the way. I sometimes will talk with people about, sometimes my travel schedule is such that, I don't put my eye drops in, or I don't do the things that I should be doing. And that frees them up to be able to say, I really have struggled with this. And then we can troubleshoot what gets in the way. Second, and we'll talk about that in a second. Second thing that usually people will ask is, what kind of side effects are you having? Now, from a behavioral paradigm, what you are doing is reminding the patient that the medicine's giving them side effects. That's the next thing that you're doing. Rather than saying, is the medicine still helping you sleep? Is the medicine still improving your mood? Is the medicine helping with the voices? So that what you want to do first is ask about the improvements that the medication
Emphasize the
is.
benefits first.
Exactly. And then, are you having effects from the medicine that you don't want? And how can I help with that? So even from a behavioral point of view, thinking about how you're framing the questions and what you're doing in terms of reminding the patient of the benefits of the medicine is really, really important. Then, what we have to troubleshoot is where the troubles with adherence lie. And there are two buckets that they go into. One bucket is the behavioral paradigm, and the other is the cognitive paradigm. And you have to sort out which is which. Most adults don't think about taking medicine as forming a new habit. They really don't. They think that they get the medicine, they should just be able to take it the way the doctor tells them. And they don't necessarily think, well, what is it going to mean to remind myself of doing that? They don't necessarily think I need to pair it with certain activities, or I need to put it in a place where there's something I do every single day, and the kinds of things that might disrupt a new habit. So you might want to think about putting a log together, figuring out what obstacles might exist. The obstacles for a person in a college dorm is going to be different from a person who's living in a shelter. It's going to be different than somebody who's got stable housing and a very predictable work schedule.
Yeah.
And you need to think about, how do I individualize habit formation for this particular person? And I mean, we have all kinds of tools that help with that, like pill boxes, etc. So that's one end of things that we might work with. And another end of things would be looking at cognitions that might interfere with taking the medicine. And those could be from as simple as needing more education about how medicine works and this particular type of medicine, to beliefs about medicine that the person has or that their family has, to beliefs about physicians or drug companies or all the rest. So you might ask the person what thoughts they have about this particular kind of medicine, or when they thought about taking the medicine during the week, what came to them, so that you can start to troubleshoot that as well. And again, those are all the interventions that you can make relatively in a short time period.
So very important follow-up to this is, so both if they're having difficulty remembering to take the medicine, or in my case, like I often wonder, like, did I already take it or did I not take it? That
Exactly.
happens to me
Right,
all the time.
right.
So those kind of behavioral, what you're calling the behavioral
Right.
bucket, and the negative thoughts or negative
Is
beliefs
the
related to taking medicine are the cognitive. Are you recommending that we address these proactively, or should we wait until the person says they have forgotten,
Right.
etc.?
So I address some of them proactively initially when I talk about starting to take the medicine every day. So the first question I'll ask the patient is, how likely is it that you're going to take this medicine that I'm going to give you today? Is there anything you think that might get in the way of that? Sometimes I'll get the cognitions right then if there's going to be that. And I'll say, can you think with me of some reminders that you might set up for yourself? Like for you, for example, one thing I'd suggest is that you have a pill box with the days of the week and that you actually make a phone alarm about when you're going to refill that box. Because the pill box is only as good as when you fill it the same time every week and
Right.
you know that the pills were in there.
Right.
That's a very helpful thing to do.
Yes.
I mean, there's a reason that birth control comes in a package that has the days labeled, so you know what doses that you may have forgotten, and
Right.
we just don't always do that with psychotropics.
Right. Right. So depending on the what problems the person has,
Then that
you
will
will
determine.
recommend like what a particular intervention. So there are a lot of people. One of the common so the behavioral things are maybe a little bit easier to deal with. The negative thoughts are hard to deal with because it's very widespread belief. I don't want to be on any medication. That's a very common thing we hear because I guess it means to the person that they are sick in some way. So what would be ways of dealing with these negative thoughts? Because I
Right.
think simply telling them that the
Sure.
medication is essential is not sufficient. They kind of know that.
So I think it depends on the kind of negative thoughts. So for example, many people have negative thoughts about psychotropics. That it's not just I don't want to be on medicine. It's I don't want to be on these medicines because it means that I'm crazy or I'm weak,
Yeah.
etc. And so one of the things I will often ask people is, well, would you say the same thing if you had diabetes and I said that you needed insulin? So that we actually are looking at widening the field and potentially looking at if this is a specific thing about these drugs. What would you say about this particular situation if your daughter was depressed and needed medication? Would you say that your daughter was weak? Or if your sister, or somebody that's close to the patient, for example. So that we're widening, again, the
Right.
field of vision and perspective. Notice I'm not telling the patient, oh, you're not weak for taking this medicine, but I'm asking them, would they have the same thought about another person? Because, in fact, that's very, very helpful sometimes to get a different perspective. I think that it's worth being able to acknowledge that it's really true that most people would rather not have an illness, but that it is also true that illness is relatively ubiquitous.
Right.
Sooner or later we'll all get something,
Right.
unless we're really genetically gifted or die very young.
Yeah.
And so, I mean, that's really something we have to contend with. I think one of the things about psychiatry is that we are practicing in a realm where most of our patients develop a chronic illness at a relatively early age in life. And so, and I think sometimes people neglect to sort of parse out in their own mind the existential reality of that and being able to speak to the fact that, this is a really tough thing. It's really true. It's really not fair. It doesn't help to not take the medicine, but you have to learn how to be a well person who has this illness.